Now, the second part of this first half of the morning is another important question. Is imaging overused in diagnosing movement disorders? So we are not speaking only on PD, but also other movement disorders. And the first speaker is Angelo Antonini from Venice, Italy, who has worked a lot on brain imaging.
Thank you, everyone. I think thank you, Amos, for inviting me here. And I think that some of this discussion, the next topic, is highly linked to what we just heard. I mean, and I think I would like to make a point very important for many of you who are here. We need to distinguish what is between the clinical and the research use, and also this applies, of course, very much to imaging, which is an excellent research tool. But in general, clinically, there are still some drawbacks which we'll try to highlight to you. Now, in the recently published ENS guidelines for diagnosis of Parkinson's disease, even if there was a lot of discussion whether the definition should be redefined, the clinical diagnosis of Parkinson's disease was still referring to the use of the UK brain bank criteria. So I think that the UK brain bank criteria never, even if I think there was a lot of discussion about this, never included imaging or a positive imaging as a diagnostic instrument to either confirm the presence of Parkinson or support the presence of Parkinson, or alternatively to exclude the presence of Parkinson. So I think this is already an important point. A lot of this discussion has already been ongoing. But I will try to show you some examples. And I will focus on three methods. One is the transcranial sonography, which is very popular here in Germany, and then MRI and DAT scan, DAT imaging. So certainly when some groups here in Germany, particularly Daniela Berg and others, started showing us that using transcranial sonography, you could identify specific changes in the brain of Parkinson patients. We were all quite excited for the reasons that Tony Shapira just mentioned to us. So we need a biomarker. And this is a relatively non-invasive biomarker that could be applied to large population series, very cheap, and relatively easy to use. The problem is, of course, there are two sort of problems with this. Number one, I mean, you can see that the imaging definition of hyperechogeneity requires, of course, some skills from the investigator. You clearly see the difference between a Parkinson and normal, but if you're not an expert, it's not trivial to identify this in some cases. Plus, and when we wrote the recommendations for diagnosis and we looked at imaging, and both myself and David Brooks were part of the team, we and Daniela Berg listed the evidence supporting transcranial sonography in diagnosis of Parkinson's disease. You see that there is the sensitivity in clinically established Parkinson is relatively high, but if you pick up other diseases and differential diagnosis between Parkinson and essential tremor, for instance, it becomes much lower, with about 20% of cases which would be misdiagnosed. And when we had to list the pros and cons of this technique, clearly there are either clinical or technical requirements that limit the application of this technique for diagnosis of Parkinson's disease in a clinical routine setting. First, the hyperechogeneity occurs in about 10% of the healthy population. We still don't know why this is the case. Maybe these people are at risk to develop Parkinson at some point in their life, but we do not know that yet. Nigral hyperechogeneity occurs also in other people, in people who have other neurodegenerative diseases and heavy metal storing diseases, for instance. There is some subtle evidence that there is a progression, so that this somehow this hyperechogeneity may be also aggravated by age, but we do not have that much data in elderly people. And plus, there are technique requirements which are quite strict. First, you need to use machine cutoffs. The quality of the temporal bone window is relatively poor in about 10% of people, so 10% of people who will come to the examination won't be able to be imaged in the brainstem. And there is a requirement for experience of the investigator, and to Daniela Berg, I had to recognize that she's made an effort to make this more available and standardize this technique. Let's come to MRI. In the clinical routine setting, I mean, we all know that there are specific anatomical changes when we looked at the brain of people with atypical Parkinsonism, particularly MSA-P, MSA-C, cerebellar type, and PSP, that can be used potentially to characterize these disorders and differentiate them from Parkinson's disease. And some of them are well known to you, the hyperintense REM on the lateral portion of the putamen, for instance, that you might see in the FLAIR, proton density, or T2, or the hot band cross sign and the enlargement of the fourth ventricle, and the hyperintensity of the middle cerebellar pedunculus in MSA-C patients. All of this is quite typical of cerebellar involvement in this disorder. But just briefly, this is a case which I've been following over the year. I'm not going to show you the video, but she had a relatively typical MSA-P manifestation. But when I looked at that back at the first MRI that she did, the routine MRI, she looked pretty normal. And only 4 years later, she developed a typical hyperintense REM, which characterizes this MSA-P disorder, which expresses gliosis in the basal ganglia. So whether this anatomical changes are characteristics or not of this disease, yes. Are they occurring early in the disease course? Very likely they are not, at least in the majority of patients, and at least using our standard techniques, routine MRI, they are pretty hard to be picked up. So I wonder whether they could be used for early clinical diagnosis. And the same, I think, is true also, even more true for PSP, where we know that there are this hummingbird sign and midbrain atrophy are characteristic, but people who have tried to look at midbrain area and measure this, so this has been an effort done in Italy by a group in Catanzaro by Professor Quattrone, they found that there was a big overlap. I mean, even people with PSP, if you look at the midbrain area, some of them, there was a significant proportion of them who overlapped with MSA-P and PD, and also in the healthy control range. So it has a lot to do probably with the time when you do the scanning. So if you do it very early, very likely you won't be able to see this anatomical change. If you do it late in the disease course, when the clinical diagnosis is established, then it becomes a clear-cut phenomena. And then the Pons area, you see that there is a big overlap between PSP and MSA-P, so between a tauopathy and alpha-synucleopathy, with extending also the range of Parkinson, and which brought us to conclude in the recommendations for clinical diagnosis that these specific abnormalities to differentiate typical Parkinson for PD have a sensitivity in early stages seems to be insufficient. So all of this to tell you that if you have to rely on imaging in an early case to make your diagnosis, you may be wrong. And you need to use strict clinical criteria. So I think the revision of I quite liked what Jens told us before. So we need to make the field not more confused, but much clearer than it has been in the past. And I think we need to use clinical criteria and try to identify a biomarker in the context of these criteria. But let's come to another imaging technique which has been widely used and discussed, which is DAT scan imaging. I've been working for many years on this, and as much as David did for fluorodopa, and now also with DAT scan. So we all pretty much aware here that this is an excellent technique to separate those people who have presynaptic dopamine nerve terminal abnormalities from those who have relatively preserved nagriostriatal innervation. Now, what is actually in the box of people who have abnormal DAT scan imaging is quite heterogeneous, and this is something which we all must be aware about. And the Certainly, in respect to Parkinson's disease, Parkinson is the bulk of the cases with abnormal DAT imaging, but also people with atypical Parkinsonism will be lying here, and people with DLB, although this may be also pretty much linked to Parkinson, would also present an abnormal imaging. On the other hand, we have been discussing many times that people with essential tremor, vascular Parkinson, or drug-induced Parkinsonism might have a normal DAT scan, and this could be a good separation point. But we also know very well that vascular Parkinsonism, for instance, if you have a lesion in the basal ganglia, you will see an abnormal DAT, but this is not linked to the degenerative process, but rather to the vascular lesion that you had in that specific brain area. And the same is partially true also for drug-induced Parkinsonism, where we have data now supporting the fact that some of the people who have been treated for a long time with neuroleptics and had initial diagnosis of schizophrenia might later develop DAT scan abnormalities with an extrapyramidal syndrome, which we do not know very well whether this is Parkinson or has somehow been related to the initial disorder. Now, what is to establish a clinical relevance for these imaging techniques, for the tracer techniques, you need to understand what the progression of the loss of dopamine nerve terminals is. And Warren Anov told us that if you take a brain of someone who has a 5-year disease duration and you look at the neuropathology, you won't see that much of dopamine nerve terminal innervation in the striatum. And this is something which we knew relatively well already from imaging, which is showing that after 5 to 10 years, only about 20% of the uptake is left from what it was originally, presumably at the beginning of the disease. Now, when is the degeneration starting is also another important point, because if imaging is a supportive biomarker and should be widely used for early diagnosis, there should be a consistency between the clinical diagnosis of Parkinson and the presence of DAT scan abnormalities before the clinical manifestations have occurred. Now, I would like to challenge the concept that if you have someone with a LAR2 mutation and maybe constipation, that person will inevitably develop Parkinson's disease. And I think all of us, and particularly in Israel, there are even more cases in the Jewish community, all of us have cases of people with LAR2 mutation who have been showing at DAT scan severe abnormalities, but they're still unaffected after a few years. So I really wonder whether these people were scanned here in Vancouver a few years ago, whether these people were unaffected. Not all of them would develop Parkinson's. So the presence of a DAT scan, even in the genetic forms of Parkinson, is not inevitably leading to Parkinson's disease. Maybe, I mean, we still do not have a sufficiently long follow-up. And also in this series, I mean, interestingly, there was one case who apparently fulfilled the diagnostic criteria of Parkinson, but had a relatively normal imaging, scanning. So there is some discrepancy, which is preventing, in my opinion, to widely apply this technique as a clinical biomarker supportive of the initial diagnosis or replacing the initial diagnosis of instruments for Parkinson's disease. Another case is a corticobasal syndrome. We published together with the group in Pisa 4 cases who had initially normal dopamine transporter imaging and where of corticobasal syndrome, where imaging was normal at the beginning, and only 1 year later it became, in the same cases, markedly abnormal. And the loss of dopamine transporter in these 4 cases within a year was 35% in the putamen. So there was a marked drop, but had we relied on the first scan and knowing what we currently have based on the historical imaging data on corticobasal syndrome, we would have claimed that someone who has a normal dopamine transporter, a normal basal ganglia dopaminergic innervation early in the disease, even if it fulfills the clinical criteria, would not have CBD by any chance, because you would expect that there is a loss of dopamine transporter and dopaminergic innervation in that brain. But we now know that this may be a later phenomena, and then there are cases occurring more with apraxia and other features early and later develop the basal ganglia involvement. And also, in another series that we did together, again with the group in Pisa, we looked at people who had isolated forms of tremor, so rest tremor and postural tremor or mixed tremor. Well, even if some of them, we prospectively followed them up for 2 years, and even if some of them did develop, evolved into Parkinson, about 25% of people who had abnormal DAT scan and idiopathic rest tremor, something which may be challenged as a diagnosis, but they only had rest tremor as an initial clinical sign. They still had rest tremor 2 years later and did not evolve to Parkinson. And the same was true for postural tremor and the mixed tremor forms. But let me finish my talk with addressing the issue of sweats, because this, I think, we just had a publication in neurology, which I will discuss with you from I think that Warren was involved in that study as well, in the PREDICT PD, which actually is putting, I think, giving us additional data and information on what the role of imaging might be, or that imaging in the clinic. Well, there's been a lot of discussion about the fact that the earlier you try to apply the diagnostic criteria, the greater is the inconsistency between imaging and clinical criteria. So the people who are if you make a diagnosis based on criteria for clinical trial, so you assume that this patient is entering a clinical trial, has at least 2 of the 3 cardinal symptoms of Parkinson, that patient would fulfill UK BREM criteria for Parkinson's disease, but that turns out to be normal. And this can be as high as 14%. That was in the L-DOPA study. And Kailash Bhatia and others argued, well, this 14%, it is because all these people have tremor forms of Parkinsonism, which are not actually Parkinson, but they've been misdiagnosed as Parkinson, and they rather have dystonic forms of tremor, so that there is a high chance of misdiagnosis of dystonic tremor to be diagnosed as Parkinson early in the disease course. And if you do neurophysiology and DAT scan, you will be able to pick this up. Now, in neurology, just that was after the talk had been assigned, so it came to, I think, in my opinion, to my support. The results of the PRECEPT study were published, and it is quite interesting to observe that it took 2 years to Ken Merrick to get the paper into neurology. So I think it was quite a tough delivery. It must have undergone, I heard that they had a lot of problems, but a lot of tough reviews. So it is quite unusual to see such a long process for publication. But the results, I think, are interesting because it's the first prospective follow-up of people who had been initially classified as SWET, so scans without evidence of dopaminergic deficit. These people were enrolled into the trial because they had a relatively short disease duration, about a year, and they were considered to be Parkinsonian, and they were scanned, and the scan was normal. Now, let's look at the clinical features of these people. First of all, it was approximately 14%, which is what you would expect as a percentage of SWED in people who have approximately 1 year disease duration. Now, the clinical features of these people are interesting because the UPDRS score was slightly mild, but was still the motor UPDRS, they had approximately 13, which is not, I mean, a small score. And the ONNR stage was similar. At prospective follow-up, which was approximately, I think, 2 years later, these people did not show changes in the dopamine transporter as opposite to people who had initially a DAT scan deficit. And if you look at the need for dopaminergic treatment, you see that this is interesting because approximately 20% of these patients with SWED still require dopaminergic therapy, even if they had a dopamine transporter scan normal at time 0 and 2 years later. So even if they had a preserved dopaminergic innervation, both points, the investigator felt that there was a requirement for dopaminergic treatment in about 1 case out of 5. And if you look at the diagnosis that the investigators apply to these people, I think it is quite amazing, because by 2 years, so scan 2, so 2 years later observation, still the investigator felt that almost 44% of these sweat cases still had Parkinson. So still fulfill the diagnostic criteria of Parkinson's disease. So 1 out of 2. And what are the other diagnoses? I mean, essential tremor, non-PD, but then if you list here, there are all sort of, there is no clear pattern. Even one case of dopamine DRD turned out to be DRD. So, which is fine, but there was a DRD case also in the DAT deficient subject. So I wonder really whether the imaging is adding or is actually creating more confusion in the head of the investigators when they had to reassess the patient based on the initial imaging diagnosis. So this is remarkable. And also, I'd like to point out to you that among the cases initially diagnosed as Parkinson who had an abnormal DAT, there were 37 cases who had later, 2 years later, had been classified as MSA, 2 as CBD, and 5 as PSP. So this is supporting the concept that if you had to rely your diagnosis basis on that imaging, you'll be picking up a lot of cases who do not have idiopathic PD, but they have atypical Parkinsonism if you do it very early in the course of the disease. So to conclude my point, I think when formulating a diagnosis in a given patient, imaging should not be considered clinically a replacement for clinical investigation and follow-up, which is very critical, I think, based on this recent neurology paper. In a clinically established movement disorder patient, imaging does not add to therapeutic management. So it's not that we can start a treatment based on imaging, or we can change our treatment schedule based on imaging. Absence of a specific MRI or DAT binding abnormalities does not exclude the diagnosis of degenerative Parkinsonism. So I think the imaging should be used when a specific diagnostic hypothesis has been formulated, and that goes back to the initial question. Imaging is useful, but only if you have something, a clear diagnosis up in your mind, and you want to use it to confirm that the clinical diagnosis, but it only comes next to the clinical diagnosis. It cannot anticipate the clinical diagnosis. Thank you for your attention.